Hi, my name is Kimberly Schrant, and I want to welcome you to a PowerPoint presentation on Quality Improvement Project to improve nursing care for critical cardiac patients in rural hospitals. First of all, I want to thank you for your willingness to participate in this project. The data that's collected through this project, your input, has the potential to positively affect rural health nurses really across the nation. It is my hope that when my study is complete and my project is done, I will submit it for publication to several rural healthcare publications. But again, I want to thank you for this, for your willingness to participate, and just a bit of an overview about the PowerPoint presentation. It's going to consist first of a brief introduction to the project, then talk about the phases within the project and focusing on the online education which will actually occur within this PowerPoint presentation, and then a brief overview of the entire project. Thank you for your dedication to rural hospital nursing and for your willingness to participate in this project. So first of all, you may be asking, why this project? Why now? What's the purpose of it? What's the motivation for it? Well, really, the purpose of this project is twofold. First of all, I'm currently a student in a Doctor of Nursing Practice degree program. And so this project is done in part to fulfill the academic obligations to graduate with my DNP. But secondly, and really most importantly, is the dedication to rural health. I've been a nurse for over 25 years and I have a strong background in rural health care. I actually have had the privilege of working for Vernon Memorial Hospital in the home health department for over 4 years. Even after leaving Vernon Memorial, I have maintained a strong commitment to rural health care by continuing to do home care in rural communities and also working in residential services, prior to teaching in both associate degree nursing programs and Bachelor of Science nursing programs. And I will have to say, our clinical students that come to the rural hospitals come away with such positive comments. They receive an experience there that's like none other. And so we really need to promote rural hospital nursing and rural health care for our communities. And again, I did just give you a bit of a background on my nursing. Okay, and again, as I stated, I have a strong background in rural healthcare and a very strong commitment to rural healthcare. So you may think, in regards to the Vernon Memorial Hospital nurses, I've had the privilege over the years not only working with you when I was actually an employee for your home care department, but dialoguing with you when I worked in residential services and with other home care agencies. The rural nurses are integral to any type of health care that involves patients throughout their lifespan in the rural areas. And why critical cardiac patients? Why is that the focus of the education and the project? Critical cardiac patients was chosen through dialogue with your Director of Nursing, Holly Hufflin, and other stakeholders at Vernon Memorial. And also, it is supported by research evidence that critical cardiac patients are an area that rural hospitals nursing staff may have challenges with because they see these patients on an infrequent basis, and the patients can present with very similar symptoms but can actually be very significant different diagnoses despite presenting with similar symptoms. I do also want to let you know that this education fulfills your educational requirement for the month of February for Vernon Memorial Hospital. And also, more importantly, it is my hope that this project will improve your confidence and competency in caring for critical cardiac patients. Now, I just want to reiterate that this is not going to give you any information you probably don't already know. What it is going to do, this project, is to reinforce your knowledge base and provide bedside tools to help you provide care for these critical cardiac patients. So before we can actually talk about the specific critical cardiac patients, we need to have an understanding of what are the issues for rural hospital nurses. And in order to understand that, we have to understand the background of rural hospitals and healthcare and the rural populations and the challenges to nurses and really those significant issues. Okay? So when we look to improve the quality of care to that critical cardiac patient, we need to understand the rural hospital setting and the unique challenges that it presents. Rural hospitals support approximately 20% of our nation's populations. These patients present with the same acuity and complexities as urban hospital patients. In fact, your rural hospital patient tends to present with more health risks, with almost one half of rural patients presenting with an existing chronic illness. The rural hospital the rural hospital systems also have less supports. This can range from a lack of providers or a lack of specialists to also a lack of limited ancillary supports. Now, in the rural hospital, you can't just pick up the phone and call the IV team. You can't request a day off because they have a float pool and can just replace you out of the float pool. Okay? Rural hospitals also have to deal with financial challenges in really an evolving healthcare system. Primarily the change from fee-for-service compensation to patient outcome-based revenue, along with the fact that Medicare and Medicaid reimburse below what the actual cost is, has created significant financial difficulties and for rural hospitals that we don't see in the urban hospitals. And it's interesting to note that rural hospitals operate on a 2% operating margin compared to 5.9% of the urban hospitals. So what do we see for the challenges of the nurses in rural hospitals? First of all, you guys are expected to be generalized experts. You work with a wide variety of patients, and yet you have to possess and maintain an extensive skill set, though you may have some limited educational resources due to the fact that it's a smaller hospital. And you also have a smaller patient volume, and you may not see these critical patients on a routine basis. You may have only infrequent exposure to critical situations. Nurses in rural hospitals also have to possess the knowledge and skill to quickly assess a patient's status, respond appropriately, and then problem solve based on a comprehensive clinical evaluation. And that's challenging, right? You guys are supposed to be competent in several areas, even though you may not see those patients on a regular basis. And how does this affect rural hospital nurses? We do know that there can be increased stress with nurses in rural hospitals. And as stress affects all areas of our lives, it certainly will affect the care we provide to our patients as well. And again, one of the hopes of this project is that we will provide those tools so that we will reinforce the education that you already have and reinforce skills that you have used, but you just may not use routinely. We know if you work in an urban hospital, you may work on an orthopedic floor. You may work on cardiopulm at Gunderson. You may work on GI digestive. And nurses become very specialized and become expert in that specialization. Well, rural hospital nurses are experts. They just have to be experts in virtually everything. So just looking a little bit about the project implementation, you have already completed a pre-project implementation Likert survey. Okay? This is to gather data prior to any interventions being done. This actual PowerPoint presentation will fulfill the Phase 1, which is the online education. Phase 2 will be actually simulation classroom activity, and that will be done at Vernon Memorial. It will involve case studies, and it will consist of identifying education in 3 specific areas, and they will correlate with the online education that you're going to receive today. Those areas are the Diltiazem drip, managing a Diltiazem drip, looking at atrial Vib with rapid ventricular response versus supraventricular tachycardia, and then managing unstable angina versus stable angina. And these were 3 areas that, again, the Specific categories were identified through dialogue with Holly Huffland and other Vernon Memorial stakeholders. So as we said, phase 1 will be the online education. Phase 2 will be the simulation, the classroom. It will involve case studies that will directly correlate with the specific education you've received. We will have a great deal of involvement through Vernon Memorial Hospital Nursing Education. They will actually be doing the education. And what we hope to do in the case studies is to provide, again, some scenarios with some simulation, because research has showed that simulation helps improve confidence. And that's really what we're looking at. Again, you probably all have had this information, but you may not work with it on a regular basis. So the purpose of this project is to improve quality by providing tools that reinforce the strong knowledge base that you already possess. And then phase 3 is going to consist of incorporating the staff nurses into code situations in the emergency room. This will be done by the staff nurses that are on the floor, regularly being on a schedule. They will rotate through the emergency room by being alerted when there's a code situation. Okay? So the plan is that the health unit coordinator down in the ER would call up to the floor if it was your time frame, if you were available. And again, we also keep an eye to the fact of the maintaining adequate floor coverage. But letting the nurse know if she is available, she can come down to the ER and really assist in that code situation. Obviously, first starting out as a recorder, but then transitioning to a more supportive role. And doing that in an environment that is also supportive in and of itself. And then you will be asked to do a post-project implementation Likert survey to really see if this project has had any positive influence on your opinions and what you previously had recorded. Now, the post-project implementation Likert survey will probably be implemented before all of you have had a chance perhaps to go through, be on call to go down and assist with code situations in the ER. And just as a matter of time frame and making sure that we have the project done in a timely manner, we will be doing that post-project implementation shortly after the phase 2. And again, the incorporation of the code situations is kind of a final phase. And that's also a way that this project will continue to maintain the education that you have received here, or the reinforcement to your education. So, as we've identified before, the 3 areas of education are the Diltiazem drip, atrial fib with rapid ventricular response versus supraventricular tachycardia, and managing unstable angina. So first we're going to look at managing that cardiac patient on a Diltiazem drip. We know that the patients are usually converted in the emergency room, and they come up to the floor after they've been converted in the emergency room. However, we also know that patients do not always stay converted. Okay? Most often what happens is, the patients come up, they were converted, they're on a strip, everything is good, and maybe they get up to go to the bathroom and they come back and they put their call light on, or maybe their family member puts the call light on, and you come in and the patient says, I feel different. I think something has changed. Okay? And so what we've done is we're going to implement a decision tree that's provided at bedside. And again, this is a resource for you as the nurse. This is to provide reinforcement to the knowledge base you already have. And it is in accordance with the Vernon Memorial Hospital's policy regarding the Diltiazem drip. So let's take a look at this decision tree that's going to remain at bedside if you have a person on a Diltiazem drip. This is what it's going to look at. And so we see it's really just a simple algorithm here. You have a patient, Diltiazem drip for patients converted in the emergency room, either for AFib, A-flutter, PSVT, whatever. Okay? So the question is, has the patient maintained the rhythm established in the ER? Okay? So we look over here. Say the patient calls you in. It doesn't feel right, whatever. you look at that. Have they maintained the rhythm established in the ER? And you're going to look at the strip. And if it's yes, you just continue that diltiazem drip. And we have it listed as what the standard orders are or per doctor's orders, okay? Per doctor's orders. That's very important, okay? Because while there is a standardized diltiazem drip, we also know that we always defer to the per provider order. So, okay, so the rhythm is maintained. We look at the frequency of vital signs when that person comes up from the ER and is on a diltiazem drip, okay? And that's listed very clearly here. And then, so this patient is doing well. Everything's going according to what the expectation was. But we also have in here the decision tree that you need to remember to consult with that provider after the initial 24 hours, because the Vernon Memorial Hospital policy is that people are converted to oral after the initial 24 hours on the diltiazem drip. Okay, so that's the patient that everything goes well. Coming over here, has the patient maintained the rhythm established in the ER? No. So then you're going to repeat that bolus. And again, this is the standard dosage. However, we do again have that per provider order. Okay, so the patient has not maintained. So you're going to repeat the bolus. Okay, then you're going to look, did they convert? Okay. Yes, if yes they did convert, then we just continue kind of over here underneath the algorithm underneath the yes. Okay, continue with the drop, looking always to defer to the doctor's orders, and then making sure that we have the vital signs done at appropriate intervals, and then we're going to look to transition to that oral dosage. If they did not convert after that repeat bolus, then you need to do a cardiac assessment and contact your provider. Okay? And that's the one side of the decision tree for the diltiazem drip. The other side is again just a more detailed view of the frequency of vitals, heart monitor, different things, what urine output you need to look at, and then actually the routine cardiac assessment minimum of twice per shift when there is, and with titration. Okay, so that basically is it. Again, this is not something you don't already know, but maybe when you haven't seen a person on a diltiazem drip in a couple months and they come up, this is to reinforce the knowledge you already have, okay? And to provide that confidence that yes, this is what I need to do. Yes, I know this is what how I'm going to proceed. The second thing category then was atrial fibrillation with rapid ventricular response versus supraventricular tachycardia. So when we look at this, first we need to understand what these actually are. Afib with rapid ventricular response occurs when the electrical activity of the atria is erratic, right? Just running around there. Not purposeful, but is very erratic. And what happens with this? It causes more frequent ventricular contraction, an increased heart rate. So our increased heartbeat might be greater than 100 beats a minute. We know that there's an absence of a P wave, and this is very important, okay? The absence of the P wave. The patient may experience shortness of breath, chest pain. They may report a quivering or fluttering of the heart, or they may present to be without any symptoms. So that is your atrial fib with rapid ventricular response. As we continue with this and look at specifically the supraventricular tachycardia, and that's an increased heart rate above 100 beats a minute, okay? And we know that this is caused by electrical impulses that originate in the heart's ventricles. Okay, so that electrical impulse sitting is above the ventricles and just kind of spinning around there. The important thing about this is the P wave is present, but it may be hidden on the strip due to the rapid heart rate. The patient may report palpitations, feeling like their heart is racing or pounding, report dizziness, lightheadedness. They can report near fainting or actual syncopal episodes, shortness of breath, chest pain, throat tightness, and sweating. SVT may be life-threatening, so this is very important that we need to pay particular attention to this. It's life-threatening because there can be a loss of cardiac perfusion, and that really goes along with that dizziness, lightheadedness, fainting, doesn't it? And also it's life-threatening because when a patient is in SVT, it's very easy for them to transition to a junctional rhythm, which is not compatible with sustaining life. It's a very serious thing. So that's why we look at SVT and looking at that in a different context than we may look at Afib with RVR. Okay? So when we look at the decision tree, how do we know if it's Afib with RVR or SVT? Because guess what? They can present looking very much the same. So the big thing and difference with these two is that the P wave, okay? So when we look at the decision tray, we're going to look at first, is that heart rate slow enough to see a P wave? Because that's our real clue as to what if this is Afib with RVR or SVT, okay? So, is the heart rate slow enough to see a P wave? Yes. Is there a P wave present? If yes, determine regular or irregular and contact your provider. Is there a P wave present? No. You need to look at that and then contact your provider and tell them then what actually the patient has experienced. If we look over here, when you're looking at that strip and the heart rate is not slow enough to see a P wave, so we have no, then you need to contact the provider for medication orders to decrease that heart rate and further interventions, because we have to be able to slow that heart rate down to see if there's a P wave, to see if rather it's Afib with RVR or SVT. Okay? So once we have that heart rate slowed down enough to look at that strip and see if there's a P wave, then we come back over here again, is there a P wave present, and then proceed accordingly. Okay? So that is one side of the decision tree. When we look at the flip side of the decision tree, it's kind of just a condensed version of what I have talked about, with actually an example of what a strip may look like, with the Afib with RVR, and what the strip looks like with SVT. Okay? And there's also a nice diagram here underneath supraventricular tachycardia that really shows how that is a problem, because that electrical activity, as you can see there, is just setting above the ventricles and just kind of doing a reentrant electrical loop, and it's just kind of spinning around there. Okay? So that is your decision tree for Afib with RVR versus SVT. The next thing we want to look at is stable or unstable angina, and how do you differentiate between those? Now this can be a little challenging because there's some similarities, but there are some significant differences that we need to understand. We need to look at stable angina that occurs with physical exercise, does not come as a surprise, usually lasts a short time, it's relieved with rest or medicine, may feel like gas or indigestion, and usually radiates to the arm, neck, jaw, or shoulder. So that's your stable angina. When you look at your unstable angina, it can occur at any time. It has a sudden onset. Patients, report that it's a surprise to them, or they may be caught off guard. It is more severe and lasts longer, and can last indeed up to 30 minutes. It's not relieved by rest or medicine, and it can get worse over time, and importantly here, it may be a signal of a heart attack. So those are some pretty significant differences. When we look at the interventions are pretty similar, right? Okay? But what is different is how they present, and that's really going to tell you how to understand whether this is stable or unstable angina. The flip side of this, the decision tree, really gives you 4 simple questions to ask the patient. That's really going to the assessment tools to help you determine if it's unstable angina. Have you ever experienced this before? If so, what were you doing and how long did it last? Did anything improve your symptoms? And do you have a history of high cholesterol? Okay? And then we have just kind of a little diagram over there that kind of just shows the pathophysiology with that. Again, these decision trees are simple. It's not any information you don't already possess, but it provides reinforcement and it provides confidence at the bedside that you do know what you know. Okay? Now we look at putting this into practice. So this, before we actually get into putting it into practice, that's actually the end of the formal online education. Those 3 specific areas, Diltiazem drip, Afib with RVR versus SVT, and stable versus unstable angina. Okay? And again, the purpose of that is to provide reinforcement already to your already existing knowledge base. Okay? So when we look at putting it into practice, we're looking at phase 3 of the phase 2 of the education, which is actually our case studies, right? They will address 3 different scenarios. It's going to again take place in your nursing education sim lab at Vernon Memorial Hospital. And what it is, it's going to allow you to have scenarios where you can use these decision trees and actually understand the difference in the patients, despite the fact that they may present with very, very similar symptoms. Okay? And again, the final phase will be, and that's a long-term, that's the nursing staff involvement in codes. And we already talked about that, a routine schedule to assist with codes in the ER. And as always, recognizing the need for staffing on the nursing floor. That is your priority. And that the proposed policy is the health unit coordinator in the ER would call up to the floor if a nurse who was on the rotation schedule, and it may be, you may be on it for 2 weeks, a month. That is really something Holly will she will make the call on that. But they would call up and say, you know, if you have availability, we've got a code coming in, you can come down and work with the code team here down in the ER. And again, always beginning as a recorder, and as you gain experience, transitioning to a more active role. Okay? And doing that transition in a very safe, supportive environment. So in conclusion, I do just want to again focus on rural hospital nursing. There is such unique knowledge and skill set that you have to possess that it's really a specialty in and of itself. Now, some countries are awarding a specific degree in rural hospital nursing. However, even in our own country, we are recognizing this because the ANCC provides a Rural Nurse Board certification, and this recognizes that being a nurse in a rural hospital requires great diversity in practice. And you have to be a generalized expert, but competent in everything. Competent in your knowledge base, in your skill set. And that was really the purpose of this project. It's to provide confidence, which will again improve competency to care for the critical cardiac patients in the rural hospital setting. Your participation in this project is so very important because, as I stated earlier, it has the potential to positively impact rural hospital nurses everywhere. Okay, what you are doing, what your experience, your information is huge. Because rural hospital nursing is unique, it's challenging, but it is oh so rewarding. As you, rural hospital nurses, continue to provide health care for those whole rural communities that you support. Again, I want to thank you for your participation and also applaud you for your dedication to patients in the rural hospital setting. Thank you.